Question number 1. Which of the following is true regarding coarctation of the aorta? The repair before 20 years is associated with normal survival. It usually occurs just proximal to the left subclavian. After the end-to-end repair, most patients are normotensive. Ascending aortic aneurysms do not occur if a repair is performed before age 5, and Dacron patch is more commonly associated with aneurysm formation. So go ahead and let us know what you think about this. You got it? Learning opportunities. Okay, question number 2. A 24-year-old man with a history of heart murmur since childhood presents for an evaluation. His venous pressure is normal, blood pressure is normal, parasternal thrill, loud holosystolic murmur, and clear lung fields. Echo shows normal size, EF is 60%. There's a dropout in the ventricular septum adjacent to the tricuspid valve, through which the Doppler jet has a velocity of 5 meters per second. Mild TR, velocity 2.3. Which of the following is true? He needs a cath. He should have a repair of his tricuspid valve. He should have reassurance and an exam in 5 years. You should call the surgeon, or he needs to be referred to a pulmonary hypertension clinic. Not 98% yet. Question 3. A 50-year-old woman has 2 years of dyspnea and palpitations. She has atrial fibrillation. She's got an RV lift at 2/6 ESM.
Ejection systolic murmur.
It should be SEM. Okay. In the second space, left sternal edge, and a diastolic rumble at the lower left sternal edge. Chest x-ray shown. Echo shows normal LV, moderately enlarged RV. Atrial and ventricular septum are intact, and the PA pressure is 50. So here's the chest x-ray here. Okay, you're going to see a lot of chest x-rays. What's the likely diagnosis? Sinus venosus ASD, pulmonary stenosis, VSD, tricuspid stenosis, or Epstein's.
Learning opportunities.
All right. A 30-year-old woman has a history of a heart murmur. She's getting more short of breath. On exam, she's got an A wave intravenous pressure, an RV list, an ejection click with a systolic ejection murmur. The echo shows a normal LV, a normal size but hypertrophied RV. The TR velocity is 4.5 meters per second. The TR velocity is 4.5 meters per second. The TR velocity is 4.5 meters per second. That's abnormal. And the remaining images are challenging due to bilateral breast implants. Which is the most appropriate procedure? TEE, CT scan of the chest, cardiac cath to assess for degree of left to right shunt, a cardiac cath planning for your ballonatics to come in, or a cardiac cath with nitric oxide and pulmonary vasodilators to assess pulmonary reactivity. TR velocity 4.5 meters per second. Okay. Learning opportunities. Are you ready to teach?
Mm-hmm.
Okay, take it away.
Thanks very much. It's a pleasure to be here with you all. Here are my learning objectives. We're going to look at the anatomy and pathophysiology, clinical presentation and imaging of left to right shunts. We're going to look at multiple congenital valve abnormalities, including pulmonary stenosis and Ebstein's anomaly. We're also going to look at coarctation, and we're going to look at some of the cardiovascular implications of genetic syndromes. And at the end of my 35 minutes, hopefully your scores will be a lot better and you can escape from Rochester, Minnesota. So why do we need to know about adult congenital heart disease? Think about it, about 1 in 100 babies are born with congenital heart disease, and thanks to surgical success of 50 years, imaging and so on. The population now in North America is estimated to be about 1.5 million adults, more adults than children, so you are going to see them in your practice, and they need special care. This is a population that is growing thanks to this surgical success in part, at a rate of about 5% per year, so you certainly need to know how to take care of them in your practice. These are the most recent guidelines we have. I'd refer you to these, but the new guidelines, I'm promised, are going to be published later this year, so keep your eyes out. But this is what this data is currently based on in this presentation, 2008. So let's begin with simple lesions, and we'll talk about this one, secundum ASD, and every picture I'm going to show you will have anatomy and pathology correlates with an echo that is apex down. And so here you see an example of a secundum ASD, a large defect, a gap in tissue in the atrial septum. And here you see the pathology specimen. This is in the region of the fossa ovalis, in the middle of the septum. And you will notice, because this is a left to right shunt, that right atrium and right ventricle is enlarged. So that's a classic and a common defect that you will see. What do we find on clinical exam? The jugular venous pressure is either normal or just very slightly elevated. And because there's volume overload of the right ventricle, you will have an RV lift parasternally. Flow through the hole itself is silent. It's low pressure. But what you do here is increase flow through the pulmonary artery. So it's an ejection systolic murmur in the second interspace, flow through the pulmonary artery, never louder than grade 3/6. You have fixed splitting of the second sound, which every medical student remembers. And if there's so much flow across the tricuspid valve from that left to right shunt, you will have a tricuspid flow rumble, generally meaning that the shunt is more than 2.5 to 1. So they're the physical signs you have to be aware of, and the murmur is from that increased flow up the pulmonary artery. Dr. Connolly mentioned this heart-hand syndrome, Holt-Oram syndrome. You have to be mindful of that because some patients will have abnormalities in the thumb and or the radius, so an inherited abnormality associated with secundum ASD. The electrocardiogram I'll show you, it's classic, either partial or complete right bundle branch block. The chest x-ray also is classic, but we make the diagnosis on clinical exam and echo. Catheterization is unnecessary except in certain circumstances. So here's an electrocardiogram, which is fairly typical. You'll notice there's right axis deviation and partial or complete right bundle branch block associated with that right ventricular volume overload. Here's a classic chest x-ray. This is very often on the boards and a diagnosis that's often missed. So how do we make this diagnosis? First of all, you will see there is increased pulmonary plethora because there's a left to right shunt. The right atrium is enlarged, the right ventricle is enlarged. And how do we know it's the right ventricle? The right ventricle is the most difficult chamber to tell from a chest x-ray, is it enlarged? But in general, if you have this humped appearance, this vertical descent of the heart to the diaphragm, that sort of humped shape appearance, that is suggestive of right ventricular enlargement. And the ultimate clue is this. On the left heart border, this very large pulmonary artery, that's because there's a lot of left to right flow. So the first mogul on the left is the aorta. The second mogul is the pulmonary artery. It should not be bigger than the aorta. So here you've got pulmonary plethora, a big right side, a large pulmonary artery. This is absolutely classic for a secundum atrial septal defect. Don't miss that diagnosis. There's the big pulmonary artery that's a clue. Notice that it's confined to the cardiac silhouette. Here's a smaller one. Again, big pulmonary artery, slightly enlarged heart, pulmonary plethora, left to right shunt, secundum ASD. Notice in none of those x-rays was there left atrial enlargement. It's just right-sided enlargement. You don't get LA enlargement with a secundum ASD unless the patient is older meaning over 40, or they have atrial fibrillation, or there's some other thing going on, atrial fibrillation. If you see left atrial enlargement, think of primum atrial septal defect or mitral valve disease. So it's right-sided enlargement with secundum ASD. Class 3, don't need a cath. All you need is a big RV, you make the diagnosis, you close the defect. You do not need a catheterization unless you're concerned about looking at the coronaries or you're concerned about irreversible pulmonary vascular disease, which occurs in about 5% of ASDs, i.e. Eisenmenger syndrome. Otherwise, you close the hole. The natural history of an ASD is that patients tolerate it well. It's often missed because the murmur's quiet, but patients get atrial fibrillation in their 50s, often how they present. You have to know that closing the hole does not prevent atrial fibrillation, but what we do know is the earlier the defect is closed, the less likely patients are to get atrial fibrillation and the dreaded complication of stroke. And this is data from the early years from Mayo Clinic looking at surgical repair of ASD. 120 patients, largely symptomatic, and they were followed for 30 years after closure of their atrial septal defect. And what this study demonstrated is that if you were repaired under 25 years of age, your long-term survival was similar to age-matched controls. And here's the data. Let's look at it by quartiles of age. You'll see compared to patients operated under 11 years of age, survival is the same compared to control, and the same for age 12 to 24 years of age. Not surprisingly, because they don't have so much atrial distension if the defect is closed earlier. But look at the difference once you're over 25 compared to the control population. A significant difference in long-term survival. People think this is a simple lesion, it's closed, no problem, whatever age. But you see here it emphasizes that long-term follow-up is necessary and an increased risk of atrial fibrillation. So this leads to the recommendation that if you find an atrial septal defect and the right ventricle is big, you close it either with a device or surgically, regardless of whether the patient's got symptoms, because their long-term outcome is going to be better. And beware, sometimes these patients will present with a stroke during pregnancy. You get a deep venous thrombosis with an ASD, atrial fibrillation, even sinus rhythm. Clot breaks off, goes through the ASD, goes to the head, and gives the patient a stroke. So you have to be mindful of that. We can close these defects surgically, as we've been doing since the 1950s, either with a stitch or patch, and we can do a sternotomy or cosmetically a very nice inframammary incision that is invisible. Increasingly, patients want device closure, and if the anatomy is suitable, we've now got multiple devices that we can use to successfully close these holes. Let's take a question, see if you're awake after lunch. 22-year-old woman, 2 episodes of slurred speech and right hand numbness. No other medical problem. She's not a smoker, but she's on an estrogen-containing oral contraceptive. Her exam is normal, lipids are normal, ECG is normal, and you do a 2D echo transthoracic study and it's normal. So she's had a neurological event. What do you do next? Upright tilt test, ultrasound, ambulatory Holter monitor, or a TEE with contrast. Please vote. Excellent. Oh, you need no teaching at all. Very good. So, already, Nish, we're off. So you can see that you're all thinking she's either got a small ASD or perhaps she's got a patent foramen ovale, but the concern is she's shunting through something and that caused her episode. Let's move on to other kinds of atrial septal defect, and these are the ones that are often missed. This is the sinus venosus defect. This is now not in the middle of the septum, but this is posterior to the fossa ovalis. It's in the superior portion of the septum. And this one, almost always, more than 90% of the time, is associated with an anomalous right upper pulmonary vein. So this is a double whammy for the right ventricle. Now you've got an anomalous pulmonary vein plus an atrial septal defect. So this is important. And here you can actually see a couple of anomalous veins right there near to the entrance of that sinus venosus atrial septal defect. And here's an echocardiogram, which is quite straightforward. You can see straight away septal flattening, right ventricular volume overload. This patient has a left to right shunt, and it's your job to find it. Apex down, the right atrium is big, the right ventricle's big. There's only trivial tricuspid regurgitation, but the velocity is 4 meters a second. So we're worried about pulmonary hypertension. So you have to keep looking. And here from the subcostal format, here you can see there is a gap in the septum, and this is the sinus venosus defect. If you can't find it by transthoracic, do some other thing like TEE or MR imaging. And here you can see the anomalous vein and the gap in the septum, which represents the sinus venosus defect. Here again, look at this big defect. This is just from subcostal transthoracic imaging, and this is very big. This person's developed pulmonary hypertension and right ventricular volume overload. So you see RV volume overload, you have to find the shunt. You can diagnose it by transesophageal echo, as you see in this top slide, or you can use another imaging modality. And these are patients that need to have their defects closed surgically. So if you find RV volume overload, you are obliged to find the left to right shunt. If you can't see a secundum ASD, think of sinus venosus defect or anomalous pulmonary venous drainage on its own. Those things give you RV volume overload, so find the shunt one way or another. Anomalous pulmonary veins, of course, can occur in isolation. Most commonly, they drain from the right side, even into the SVC or the right atrium itself, or the IVC even, and that can be scimitar syndrome. And they can also drain from the left side, sometimes with this vertical vein that drains into an innominate vein and around to the SVC. So you need to look for this on imaging if you've got right ventricular volume overload. Remember to look at the suprasternal window, or again, TEE or MRI. Here you can see one of these vertical veins with the color flow coming up north, red flow, draining into an innominate and around to the SVC. So big RV, find the shunt, that's the message. Let's move on to primum atrial septal defect. Now this is what's called AV septal defects, atrioventricular septal defects. The terminology gets confusing, but let me just talk you through it. An atrioventricular septal defect or an AV septal defect, a primum ASD, those two terms are synonymous. Partial AV canal, it's a synonymous term. It's a defect that's in the lower part of the septum, and it's always associated with an abnormality of the AV valves. The mitral valve is usually cleft, and it's the most common defect with Down's syndrome. Now, we're going to go back to basic anatomy. You will recall that the tricuspid valve is lower in the heart than the mitral valve. Happily for us doing congenital heart disease, the tricuspid valve is always the inferior valve. It's closer to the apex. And the tricuspid valve always enters a right ventricle. This tissue between the mitral valve and the tricuspid valve, there's this little tissue here, that is the atrioventricular septum. And when that tissue is missing, that produces an atrioventricular septal defect, and the AV valves are on the same level. So here's an example. This is a primary atrial septal defect, otherwise known as a partial AV canal. There is a defect only in the septum, but you see the AV valves are on the same level, and you have a left to right shunt, so the right side is big. Echocardiogram, again, there's just a very small defect in here. You might miss it. But you see the AV valves are on the same level. And here's the problem. You can see on color there's a lot of mitral regurgitation. And you can see the flow through the defect there. Classic primum ASD, the same as partial AV canal. Here's the anatomy, a big defect, AV valves on the same level, and the mitral valve is abnormal. And when you look at it from the LV side, here's the hole, but this anterior mitral valve leaflet is cleft. It should come out of the slide like a semicircle, and it's as if somebody took a slice out of a pie. That's the cleft that leaks and causes mitral regurgitation. Surgical closure, here is what you need. This is not amenable to device closure, and the surgeon needs to suture close that cleft, and the patient should do very well. This is what it looks like on the echo, a short axis. There is a gap in the mitral valve. Instead of the fish mouth, you have a gap there. That's the cleft, and that's the one that leaks. Now, the ECG here is completely different from a secundum ASD. Yes, you have right bundle branch block, as you see here, partial or complete, but you have left axis deviation. That should give you a clue. Associated lesions, you can have a secundum ASD, but you can also have other things, VSD, pulmonary stenosis, subaortic stenosis. Sometimes those mitral cords are attached abnormally to the septum and produce subaortic stenosis. Left superior vena cava in about 10% of patients with congenital heart disease, important for pacing, and coarctation. So the more extreme form now of an AV septal defect is what we call complete AV canal. And here's what's different about it. Here you have an atrial defect, but you have a ventricular septal defect. So here's the anatomy. And here, instead of having a mitral valve that is cleft, you have one big AV valve that is above the septum. So the atrial septal defect is above. Here you have this one big AV valve that doesn't quite meet in the middle, and you can see there are little cords that are attached to the crest of the septum, and beneath here is a ventricular septal defect. Here you see the echo on the right, the atrial component, this big valve that looks like a seagull, one AV valve, and a big VSD with cords attaching to the crest of the septum. So now, again, you've got a double whammy left to right shunt, atrial and ventricular. If these patients are not repaired very early in life, within the first 1 or 2 years, they will develop irreversible pulmonary vascular disease, Eisenmenger syndrome. So this is what it looks like on the echo. Again, now you've got the atrial defect above, the ventricular defect below, and this big AV valve, and patients again have AV valve regurgitation because the valve is abnormal. Early surgery is absolutely necessary. So we've talked about partial AV canal, we've talked about complete AV canal. Now we'll move on to a simple defect, ventricular septal defect. Remember, small defects make a loud noise, often with a thrill. Patients may be asymptomatic. But big defects may be associated with a mitral diastolic flow rumble. Blood goes around, comes back around the circuit, and the mitral valve has so much flow, it may produce a flow rumble. VSDs cause left ventricular enlargement if they're big enough. And so if you see a big LV, that VSD has to be closed. If the LV size is normal, pulmonary pressure is normal, there's a loud murmur, a high velocity across the VSD on echo, you can follow that patient. Follow them every 5 years or so. Make sure the LV isn't getting any bigger. But if the LV is big, you close the defect. Remember, large VSDs, because the RV pressure is the same as the LV pressure, blood is just gently sloshing between two chambers, they never have loud murmurs. Small defects make loud noises. So VSDs are often benign. In fact, many of them close spontaneously. But the defects that are beneath the aortic valve or beneath the pulmonary valve, so-called supracrystal defects, they need careful follow-up because they're more associated with aortic regurgitation. The aortic valve can prolapse into the defect, and often we close those early to prevent aortic regurgitation. Moving quickly along, we're doing a potpourri of defects. This is patent ductus arteriosus, this communication between the aorta and the pulmonary artery that may not close in neonatal life. There you see the anatomy. These defects are associated with maternal rubella and are more common in women. This is like an AV shunt, really. They have a wide pulse pressure like an arteriovenous fistula. Patients may have dynamic left ventricle, and they may have a thrill in the second left space and a continuous murmur, sometimes called a Gibson murmur. And it completely envelops the second sound. Think of any other fistula. It may produce the similar findings. Ruptured sinus of Valsalva aneurysm may also cause a continuous murmur. VSD and aortic regurgitation may confuse you, but that murmur is not completely continuous. It doesn't envelop the second sound, but the ductus does. It's truly continuous. Coarctation, rarely, if it's very severe, you may hear a murmur because there's a pressure difference during diastole as well as systole. So continuous murmur, you have to think of those differential diagnoses. What do the guidelines say about closing a ductus? If you've got volume overload, LA enlargement, or LV enlargement, you close the duct with a device or with surgery. Or if you've got a degree of pulmonary hypertension that's reversible, or if you've had prior endarteritis on the duct, which is very rare. It's reasonable to close a small duct by a catheter device if patients are asymptomatic, but no certain benefit. And closure is reasonable if you're developing pulmonary hypertension, as long as it's a net left to right shunt. Moving along, pulmonary stenosis. This is a valvular lesion that's associated with Noonan syndrome. So again, think of these genetic associations. So let's talk about the physical findings of pulmonary stenosis now. So now we've got a problem with the right ventricle. So you see an A wave in the jugular venous pressure. You do not see a V wave. The right ventricle will hypertrophy. It will not fail until very, very late in life unless something else is going on. So you see an A wave because of the hypertrophied right ventricle, and you feel an RV lift. And since it's valvar, you will hear an ejection click from the pulmonary valve, and you'll hear a murmur. And remember that the pulmonary component of the second sound, P2, will get later and quieter with more pulmonary stenosis. Why? Because the right ventricle that's at high pressure keeps the pulmonary valve open longer, and then slowly the pulmonary valve will float into apposition if it's still moving. So P2 will be quiet. If the valve is calcified, P2 may be completely absent altogether. So they're the physical findings, and think of PS with Noonan syndrome. The earlier the click, the more severe the stenosis. Why? Because the right ventricular pressure is high. It forces the valve open early. It exceeds the pulmonary artery pressure. So the earlier the click, the more severe the stenosis, and again, the right ventricle doesn't fail until you're at least over 50 or 60, unless there's another lesion. Now, the next slide is very important for boards because it seems to recur again and again. Number one, an ejection click may be absent in Noonan syndrome because Noonan patients obviously have a thick dysplastic valve, and so it may not be mobile enough to produce a click, number one. But importantly, I want you to remember this. This is the one right-sided sound that decreases with inspiration. Everything else on the right side increases with inspiration because you suck blood into the right side of the heart when you take a deep breath in. The ejection click in pulmonary stenosis decreases on inspiration. Why? Because when you take a breath in and you get more blood in the right ventricle, it pushes the valve up a little bit, and so there is less systolic excursion. And so the click gets quieter on inspiration, the one right-sided sound. This is a picture of an extreme family with Noonan syndrome, and this is an autosomal dominant lesion. And here there's a daddy Noonan who married a woman with Noonans, and so of course they had a baby with Noonan syndrome. And the features that you look for are the wide-spaced eyes, a depressed bridge of the nose, low-set ears, and you can see that in all three of these family members. Sometimes IQ is impaired, not always. Typically they're short stature. So Noonan syndrome, remember, pulmonary stenosis. Now, the chest X-ray, again, very important. Notice here that the heart size is normal. This is completely different from the X-ray of an atrial septal defect. You do not get a big heart. Remember, the RV hypertrophies but doesn't dilate. Notice even in this patient with severe PS, the lung fields are not black. You do not see oligemia. But what you do see is this huge pulmonary artery. Mogul number one on the left is the aorta, number two, the pulmonary artery, and here it is sticking its nose into the lung fields. This is not like the X-ray of ASD. This pulmonary artery is prominent, but it's sticking its nose into the lung fields, sometimes called the witch's nose, looking like that. So remember, you see the witch's nose, pulmonary stenosis, normal-sized heart. That's a classic X-ray of PS. Nowadays, we treat these with a balloon rather than surgery, and the guidelines say if you're asymptomatic and your peak gradient's more than 60 or your mean gradient's more than 40, we can balloon them. If you're symptomatic, the peak gradient may only be 50 or more, or a mean of 30, and they have excellent results as long as the pulmonary valve isn't leaking a lot with more than moderate pulmonary regurgitation. However, any intervention on the pulmonary valve may be associated with pulmonary regurgitation. So after a valvotomy, beware the patient who comes back with a big heart, arrhythmias, and TR. Look for pulmonary regurgitation after an intervention, very important. Coarctation. Here we are with a pathology specimen, and here's an angiogram. This usually occurs distal, as you see here to the left subclavian, and so it's associated with high blood pressure in the upper limbs, low blood pressure in the legs. and you may have multiple collaterals from subclavians and axillaries and internal mammary arteries and intercostals, and of course, it's commonly associated with a bicuspid aortic valve and associated with Turner's syndrome with this webbed neck and wide-spaced eyes, and so on. Physical exam then, delayed or absent femoral pulses. You may hear the systolic murmur from the coarctation. You may hear or feel collateral murmurs at the back of the chest. A fourth sound, because they're hypertensive, and a loud A2, and an ejection click and or a systolic murmur from the bicuspid valve. The chest x-ray may be classic. In the books, you read about a figure 3 sign, but in practice, they're hard to find. But you may see rib notching. Everybody knows that. And we make the diagnosis by echo Doppler, by CT or MR, or even an angiogram. Now, here's a picture that is supposedly my best to show this figure 3 sign, the dilatation above the coarctation and the post-stenotic dilatation, but they're very hard to find. What you look for is rib notching in the upper ribs. Here's another example. The heart size looks normal. You don't see a figure 3, but look at these ribs. This is the intercostal collaterals eroding the inferior rib margins, classic for coarctation. And you have to remember that an aortopathy goes along with it, just like the bicuspid aortic valve. These patients are in danger of all the aortic complications that you've heard about already, very important with these medial changes and developing dissection or rupture. So here's the imaging. Here's a different kind of imaging. The whole aorta is abnormal in this situation, not just the bit around the coarctation. We intervene on these lesions when the gradient is more than 20, but beware. If the gradient is less than 20 and you've got a lot of collaterals bypassing the coarctation, you can still have a severe coarctation anatomically. So the gradient alone is not all that you look for. You can still feel quite good femoral pulses if you've got collaterals the size of my thumb. So you have to look at the gradient and you have to look at the anatomy of the coarct and think about intervening. Look at this one. This is very severe. So you can have a gradient less than 20 with a lot of collaterals. If you miss that Doppler signal down that descending aorta and you worry about coarctation, do another imaging like CT or MR. You need to rule it out if you have concerns. We can treat them with balloon and stents very nicely, or we can treat them with surgery. We've been repairing since 1944, and you can cut the coarct out and put the two ends together. You can do a flap repair. You can patch with Dacron, or you can do a tube graft to bypass the coarctation. But there are important messages. People think after a coarct repair, you are cured. Not so. 75% are hypertensive at 30 years, even after a good coarct repair. And patients die early with coronary disease and heart failure and stroke and the aortopathy. What we've learned is the earlier you're repaired, the better is the survival. This is data from Mayo Clinic. But notice it's not normal. 30-year survival, 72%. Mean age at death, 38. Are they cured? Absolutely not. Here we've demonstrated data that if you're repaired at less than 20, your survival is better. But is it normal? Absolutely not. New data, 30-year survival, 74%. And again, why do they die? Premature coronary disease, they're hypertensive, heart failure, stroke, rupturing, dissecting the aorta. These are the reasons these patients need lifelong follow-up, meticulous follow-up, imaging of the aorta, and beware recoarctation. Patch repair in particularly, cutting out the coarctation, is most associated with aneurysm formation. Patch repair and aneurysm formation. Here you can see that big blob on the chest x-ray, but you may not see an abnormal chest x-ray, and you need to image the entire aorta for life in these patients. Look at this thing. It's humongous. And here's a patient with aortopathy in a different location dissecting the ascending aorta. So the lessons: follow-up, perfect blood pressure at rest and on exercise with beta blockers, reduce the stress on the aorta, image the aorta for life, screen for coronary disease, and image the head because they have a 5-fold incidence of intracranial aneurysms, one of the reasons they have stroke. So, age at the time of repair predicts survival, but survival is not normal. Lifelong follow-up, perfect imaging, and associated problems are common. Lastly, this lesion, Ebstein's anomaly. Here you see this problem with this inferior displacement of the tricuspid valve and an atrialized RV above and a very large right atrium. These are a variable spectrum. 50% have an ASD or a PFO, so they may be blue. They have TR, they may be cyanotic if they have an atrial defect, and 25% have an accessory pathway, so they may present with atrial arrhythmias. They have a low cardiac output, so they may have peripheral cyanosis, or if they have a shunt, they may be centrally cyanotic. Look for the V wave in the JVP, but be careful. These patients have such a big right atrium that they can have torrential TR and have no V wave. Subtle RV lift, this RV is thin-walled. A loud T1 because they often have a large anterior leaflet making a loud noise for the valve, and you hear the murmur of tricuspid regurgitation, which comes up on inspiration. And look at this chest x-ray. This big globular heart. Is it end-stage heart failure? This is not, because look at this central shadow here where the aorta and the pulmonary artery should be. You don't see the ascending aorta. You don't see the descending aorta. You don't see a pulmonary artery. If this was end-stage heart failure with a normal heart, they would be big. But here you've got this huge globular heart, which is right atrium, a big shadow, and a very small central vascular pedicle. Those arteries, the aorta and PA, you don't see. Classic for Ebstein's with clear lung fields. Right bundle branch block on the ECG, very common. Pre-excitation if there's an accessory pathway, very tall P waves, and potentially atrial arrhythmias. And here's the ECG. Look at these P waves. Helen Taussig called them Himalayan P waves because they're almost as big as the QRS. Look at this right bundle, this very fractionated QRS, T-wave inversion, and a very abnormal ECG with these huge P waves that show you that right atrial enlargement. Nowadays, we repair many of these tricuspid valves. You don't let the heart get that big with Ebstein's. If patients complaining of diminishing exercise capacity, they're blue, they're at risk of stroke, the tricuspid valve is leaking a lot, they have a bypass tract, or their RV is very large, we repair or replace the tricuspid valve. Here, our mortality is about 1 or 2%. So, lastly, to remind you the CV implications of genetic syndromes. Holt-Oram, heart-hand syndrome, secundum ASD, Downs, AV septal defects, Noonan's pulmonary stenosis, Turner syndrome, coarctation. If the RV is enlarged, find the shunt. It is not pulmonary stenosis. Secundum ASD, if the RV is even slightly big, you close the hole. Other ASDs require surgical closure. With a VSD, the LV gets enlarged, and if the LV is big, you close the VSD. Severe pulmonary stenosis, more than 60, balloon intervention, coarctation, intervention if the gradient is more than 20, and lifelong follow-up with imaging of the entire aorta is mandatory. Prophylaxis, I'll just touch on just to remind you what the endocarditis guidelines suggest. There's very few indications for bacterial endocarditis prophylaxis now in these simple lesions, but of course, with prosthetic valves, cyanotic heart disease. And if there's something that's not endothelialized properly, or you've put in a device or done surgery, 6 months afterwards, you require prophylaxis. After that, not. And you don't require it for GI interventions at all. So we've rattled through a lot of defects. Don't quit. We're only halfway through. Thanks very much.
All right, a whirlwind of, and remember that's simple, so when you come back, you'll really hear about complex. Okay, which one of the following is true? Have a seat, Dr. Warrens. Regarding coarctation of the aorta. Repair before age 20 is associated with a normal survival. It usually occurs just proximal left subclavian. After end-to-end repair, most patients are normal tensive at follow-up. Ascending aortic aneurysms do not occur if repair is performed before age 5, and the Dacron patch repair is more commonly associated with aneurysm formation. So which one of these is true?
I can't see the number. Is it 90-something?
No, it's not. It's 92.
Oh, poo.
Use the microphone, sit back, and talk to us.
Well, I can't see if I sit back, so obviously the Dacron patch is the most appropriate answer. They're all associated with complications. In terms of number one, the most important thing with this defect is it's never completely fixed. So however it's repaired, and whatever modality is used to repair it, and however old they are when it's repaired, they will do better the earlier the time of surgery or intervention, but their survival is never normal. And it's not normal because of this aortopathy. So you can get problems with dilatation, dissection, rupture, recoarctation, all the other problems I mentioned, premature coronary artery disease. But this is not a lesion that is, quotes, corrected. This is a lesion that is repaired. And so whatever age they're repaired, survival, unfortunately, remains not normal.
Okay, now, do you want to summarize from a practical standpoint? Guy comes to you, had previous coarc repair 30 years ago. He's like 40 or 50 years old. What do you do in terms of MR, CT scanning, treadmill testing, and how often?
So the first thing, of course, is a good clinical exam. You want to know, does he have a bicuspid aortic valve, which is a common association? And so do they have a click? Do they have a murmur? You need to evaluate all of that with imaging, obviously, and the echo is a good place to start with the valve, the ascending aorta, looking at the coarctation site, which is hard to see with transthoracic imaging, and try and get a Doppler down the descending aorta and see if there's a gradient. And importantly, Doppler the abdominal aorta to see whether the flow is normal. That's very important. If the flow in the abdominal aorta is normal, that gives you a good chance that the coarctation site has not re-narrowed. And again, your clinical exam, feeling the pulses, looking at BP in the legs is important. But you also need to do other imaging because you can't see the entire aorta on an echo. You can use MR or CT, but since they need lifelong imaging, it's important not to expose them to radiation on a regular basis. So MRA of the aorta is one of the modalities we use most commonly. Blood pressure must be perfect, and it must be perfect on exercise. Some patients will have normal blood pressure at rest, but you put them on a treadmill and it may go sky high. And obviously if you've got a fragile aorta, you don't want them having blood pressures of 230 when they're out jogging. So exercise testing on a regular basis is important. If everything looks great and imaging is normal, exam is normal, and so on, you might just say, we'll see you again in 2 years. If things aren't quite so good, depending on the size of the aorta and so on, you might say, we'll see you back in a year, or if there are issues with the aorta, you might be looking at another intervention.
But how often do you do an MR scan if your aorta is not dilated?
If it's not dilated and the coarctation repair site looks good and there's no aneurysm, we'd probably not do another MR for at least 2 years, maybe 3.
Okay. All right, so let me see. That was, okay, that's your good questions. Now, a 24-year-old man, history of heart murmur since childhood, presents for an evaluation. His venous pressure is normal, blood pressure is normal. He's got a peristernal thrill and a loud holosystolic murmur with clear lung fields. Echo shows normal LV size, EF 60%, and there's an echo dropout in the ventricular septum adjacent to the tricuspid valve through which the Doppler has a velocity of 5 meters per second. He has mild TR, velocity 2.3 meters per second. Which of the following is true? He needs a cath, he needs a surgeon, he needs nothing except reassurance, he needs a surgeon for his VSD, or he needs to go to pulmonary hypertension clinic. '88.
Oh, rats.
They can't hear you without the mic.
No, I'm just looking to see where the problem was. So the correct answer is reassurance. So he's got a VSD. Everything is consistent with that. He's got a loud murmur, which would suggest that it's a small hole. His LV size is normal. You can see an echo drop out through the ventricular septum, and the velocity is high through that VSD, and the TR velocity is normal. So he doesn't have any pulmonary hypertension. His LV size is completely normal. So this person, apart from making sure he goes to a dentist regularly, requires no other intervention at all, except just occasional follow-up, perhaps every 3 to 5 years, with imaging and a clinical exam.
And is there any VSD that's small that you might want to repair because of its effect on anything else?
So the defects that are beneath the aortic valve, subaortic defects, and the defects that also sit immediately adjacent to the pulmonary valve, what used to be called supracrystal VSDs, can be associated with progressive aortic regurgitation, because as they're beneath the aortic valve, the aortic cusps can kind of prolapse into the defect. And so in those patients, in some circumstances, even though the VSD may be small, if you're developing aortic regurgitation, you close the defect early and resuspend the aortic valve leaflet so you don't end up with a patient coming back late with aortic regurgitation needing a valve replacement. So they're the ones that you close sometimes even if the VSD is small.
Okay. 50-year-old woman, 2 years of dyspnea and palpitations, now has atrial fib. Examination is an RV lift, a 2/6 murmur, a diastolic rumble. Her chest x-ray is going to be shown. The echo shows a normal LV, enlarged right ventricle, and the atrial and ventricular septum are intact, but there's some mild pulmonary hypertension. So show the chest x-ray. There's the chest x-ray. You're looking for a witch's nose. I can't see a witch's nose.
Stop giving it away.
So what's the most likely diagnosis? Sinus venosus, pulmonary stenosis, VSD, tricuspid stenosis, or Ebstein's anomaly?
Shall I go up and show you chest x-ray?
That's okay, because we only got a minute or so. 77%. Some people said pulmonary stenosis. Better put that chest x-ray back up.
I'll go and point.
You don't have to point, just...
So you forgot the witch's nose. So first of all, this heart size is a bit big, right? And remember, in pulmonary stenosis, the heart size is normal. It does not get big. It hypertrophies, but it doesn't dilate. And this has right ventricular enlargement because you have this humped appearance, and the contour of the heart comes down vertically towards the diaphragm. There's a sort of shoulder here. That's strongly suggestive of RV enlargement. and the pulmonary artery is bigger than the aorta, but it's confined to the heart border. The pulmonary artery is big because it's got a lot of flow. And you've got pulmonary plethora. There's increased flow in the lungs here from the left to right shunt. So this is classic for some left to right shunt atrial septal defect.
So as you're coming back, one of the questions that was asked in your talk, you had one of these anomalous pulmonary venous or sinus venosus, and the young woman had a paradoxical embolism where you had neurologic symptoms. So they asked, well, how can she have neurologic symptoms if you have left to right shunting?
Because just like with a PFO, and you know all the controversy about whether PFO is associated with stroke, there are times in the cardiac cycle when clot can go right to left, even if the shunt is left to right. So some young women, as I mentioned, for example, in pregnancy with an atrial septal defect, you get a DVT, that shunt may go right to left at some time during the cardiac cycle. So even though the shunt is left to right most of the time, you may have some right to left shunting, and they are all vulnerable to paradoxical embolus if you have any kind of atrial septal defect.
Okay, one last question. 30-year-old woman has a history of heart murmur, comes from an evaluation because she has dyspnea. She has an A wave in her venous pressure, an RV lift, and a loud systolic ejection murmur with an ejection click. With an ejection click. With an ejection click. The echo shows a normal LV, normal size but hypertrophied RV, and the velocity is 4.5 meters per second of the tricuspid regurgitation. Which is the most appropriate procedure in this patient who has a witch's nose? So do you want to do a TEE, a CT scan, a cardiac cath to look for shunt, a cardiac cath to do a balloon, or a cardiac cath with nitric oxide?
Give us a head.
Oh, even with that, Dr. Warrens, you only got 90%.
God. So obviously this person has pulmonary stenosis. What did they say for the other thing? Were they doing a TEE? I didn't see what the... So transesophageal echo is not very good for looking at the pulmonary valve. It really is quite challenging. You can try and do it, but really the best thing to do is a good transthoracic study. And in this case, everything is absolutely classic for severe pulmonary stenosis. There's the ejection click, the systolic murmur, the witch's nose, as Nish said, for the clue. So there's nothing wrong with doing a TEE, but will it help you? Will you image the pulmonary valve very well? Chances are not. So everything is consistent here. You could take the patient to cath. You could do other imaging if you want to look at the RV outflow, like MR or CT, but essentially there's enough here to say pulmonary stenosis. Take the patient to cath for consideration.
Wait. But you never saw the pulmonary valve or got a Doppler across the pulmonary valve. Are you that confident of your exam?
I would be.
All right.